Fighting Blindness Canada's Viewpoint Education series shares the latest vision research, provides opportunities for you to ask your questions, and connect with other people who are living with a blinding eye disease. The session you're about to watch is a recording. To learn more about the research we fund and upcoming programs and events, please visit our website at fightingblindness.ca. Viewpoint is proudly supported by our presenting partner Meyer, our connections partner Roche, and silver partners Astellas and Beacon Therapeutics. Please note that the views shared by our speakers are their own and do not necessarily reflect those of Fighting Blindness Canada. Mention of any products, treatments, or services does not constitute an endorsement, and sponsors do not influence the content of our educational programs. This webinar is for educational purposes only and should not replace medical advice from your healthcare provider. Thank you for watching. We hope you enjoy this session and share your thoughts with us in the comment section below.
Welcome. It's really exciting to be here today. I think this might be our largest glaucoma webinar, and as Morgan said, really fitting that it is taking place during World Glaucoma Week. I think a great time to have this conversation. And yeah, so for the next about 30 to 40 minutes, I'll be talking with Dr. Wang and Dr. Meyer about glaucoma and optic nerve conditions. So what's happening in the eye when damage happens, and how are researchers starting to work towards new ways to protect or even restore vision. And there will be quite a bit of conversation about the restorative part of the research that's taking place. So now let me introduce you to our panelists. So I'll ask Dr. Wang and Dr. Meyer to put their cameras on right now. So Dr. Qianqian Wang is an ophthalmologist specializing in glaucoma and cataract surgery and an associate clinical professor at the University of Montreal. She is actively involved in both clinical care and research related to glaucoma. And we're also pleased to have Dr. Jason Meyer, who is a professor of medical and molecular genetics at Indiana University and director of the Stark Neurosciences Stem Cell Research Group. His research focuses on stem cell biology to study neurodegenerative diseases, and that includes glaucoma. So thank you both very much for joining us.
Thank you. Thank you for the invitation.
Thanks. Pleasure to be here.
Yeah, so we've briefly met our speakers and we'll be talking to them a lot more. So let's just jump into the conversation. And I'm going to start with Dr. Wang. So as I mentioned, we've really positioned the session around the glaucoma and optic nerve conditions more broadly. So to start us all off, I was wondering if you could explain what the optic nerve does and what happens to vision if the optic nerve is damaged.
Of course. And thank you once again to Fighting Blindness Canada for this opportunity to talk about a subject that's very dear to my heart. I think to understand the role of optic nerve, I think it's important to review how the human visual system works. So first of all, for somebody to be able to see well, first and foremost, we would need an eye that's in healthy shape, so that it can capture all those visual information, the light from our environment, and particularly inside the eye, there's this group of highly specialized cells called retina ganglion cells, which I'm sure we'll hear a few more times throughout the webinar. So these cells are very performant, very good in capture those signals and then transmit the message through an extension of themselves. We can imagine them as micro wires that will come together to form what's known as the optic nerve. So the optic nerve truly is the cable conveying these visual messages from the eye to the brain so that this information can be further analyzed and make sense of. So the person will know, okay, here I'm looking at a flower or I'm looking at a cup of coffee. So as you can imagine, for whatever reason that there's injuries or damages happening to this cable, our vision won't be very good, even if we have a healthy eye or a healthy brain. And with the medicine available in 2026, damages in the optic nerve largely lead to irreversible vision loss.
Thank you. That was a really great description. And that's how I imagine the optic nerve is essentially a series of sort of cables, or one cable with lots of different wires inside it, exactly. With each wire being a different retinal ganglion cell. I know we're talking about optic nerve conditions more broadly, but one of the most common causes of optic nerve damage is glaucoma. So I was wondering if you could talk a little bit more about what happens in glaucoma to cause optic nerve damage, and what does this mean for somebody's vision?
Of course. So indeed, I mean, we wouldn't have a World Glaucoma Week for nothing, and it is actually one of the leading cause for irreversible blindness in the whole world. When we look at glaucomas, or when we talk about glaucoma, I think most people in the audience are quite familiar with the term of intraocular pressure. So this is one of the important mechanisms that will cause damages on the optic nerve through more of a mechanical stress spectrum. So as you can imagine, previously we talked about those micro wires, those fibers coming together and getting outside of the eye. So if within the eye there's constantly high pressure, it's really going to cause repetitive stretching, crushing movement of these really delicate and very fragile structures. And as you can imagine, over time, it will lead to damages and subsequent vision loss. And aside from this pressure-dependent mechanism, there are also tremendous research done on other mechanisms. So it's not just one cookie cutter focusing on pressure. Another main thing that we need to consider is the vascular component. So same as all the other tissue in the human body, our optic nerve is dependent on a proper blood supply. And for whatever medical reasons that will compromise that blood supply, hence compromising the oxygen or the nutrient delivery to the optic nerve, we can imagine, the end result won't be very good. It will be, first of all, starting with not working to its full capacity, and then slowly withering, and even in the worst case scenario, cause several deaths. And finally, I think, we talked about the mechanical stress, we talked about the vascular component, and what's important to realize that either of these components or a combination of both usually can trigger a number of cascades of events that will lead to delayed response, a delayed distress that will further damage the optic nerve. In consideration of the time limit, I'm not going into details, but things that scientists are currently looking at include neuroinflammation, things like mitochondrial dysfunction, or axonal transport disruption. And on this, very quickly, the optic nerve not only deliver visual images from the eye to the brain, but also is a pathway for the brain to be able to send neurotrophic factors in a way we can understand as essential vitamins for the optic nerve to survive, to maintain its well-being. So it's also a pathway for this delivery. And if there's a disruption in that, it would also lead to compromise in the house of optic nerve.
Thank you. I mean, so yeah, lots of complicated things happening in the eye when there is glaucoma. So you're saying there's a physical stress, there's changes to how the blood is delivered. There's also changes to how the brain is potentially communicating back with the eye, and inflammation. I was wondering what all of these things mean for somebody who has glaucoma. Like, how would that change how somebody is seeing? What are the effects they might see, first of all, when they're initially diagnosed? And if glaucoma progresses, what could their vision look like?
It's a very, very important question. In reality, it's not for nothing that glaucoma sometimes it's called the silent thief for vision. And thankfully, with our universal health system here, the great majority of my patients come to see me when their condition are still largely asymptomatic. So, the disease can stay silent, not really giving any red flags. It doesn't really cause pain or immediate visual symptoms early on during the disease process. But unfortunately, in a minority of patients who come presenting more in an advanced phase, their vision will be significantly impacted. The typical glaucoma progression vision loss usually starts with the peripheral. This being said, there are also patients who can have earlier central visual field involvement, but overall, I think the great majority do start with more of a peripheral vision loss that will slowly close in, and worst case scenario can lead to permanent blindness.
Okay, so and really quickly before I jump to Dr. Meyer, I know there's other causes of optic nerve damage. So can you maybe just sort of tell us at a high level if somebody has optic nerve damage from another source, another eye disease, for instance, stroke, would their vision also be impacted in a similar way as glaucoma, or would there be big differences?
So there are different conditions that can mimic glaucoma. That's why I always tell my resident and fellows, not everybody who walks into a glaucoma clinic actually has glaucoma. So, we do have clinically, we do have a list of potential red flags that I'm always, keeping in mind. And fairly frequently, that, when a patient shows something that's atypical to glaucoma, that will prompt me ordering further investigations. So there are similarities, but glaucoma has its own characteristic changes that can differentiate itself from things like stroke, or let's say vision loss from, let's say, a tumor or any other central causes.
Okay, thank you so much. Dr. Meyer, I'm going to turn to you now. And I know Dr. Wang has given us a really good description of sort of physiologically what is happening in the eye. And she started to talk about retinal ganglion cells, which I know you are very, very familiar with. I was wondering if you could tell us a little bit about what's happening inside the cells when there is damage from glaucoma or another cause of optic nerve damage.
Sure. So yes, Dr. Wang did a really excellent job really describing the retinal ganglion cells, or they're often called the RGCs for short. Um, and fundamentally, glaucoma is a neurodegenerative disease of these retinal ganglion cells, or the RGCs. Um, these RGCs are the neurons whose axons form the optic nerve, and these are like the only connection then between the eye and the brain. So in a disease like glaucoma, any kind of stress is going to damage the axons of the cells, which really damages the only connection between your eye and the brain. So typically in glaucoma, we often think of this stress coming from elevated pressure in your eye. And in many cases, that is the case, but it's not always the case. There are other things that can introduce stress, but there is a stress on these connections between the eye and the brain. And then this kind of stress on those connections, on those axons, will do a variety of things. It's going to disrupt some of the transporter materials between the eye and the brain. That's going to be important for the survival of the RGCs, for proper conduction of neural signals to take that visual information that enters your eye and connect with the brain. And over time, these axons will degenerate. So they're fully disconnecting from the brain. And then even the cell bodies of the RGCs in your eye will start dying off also. So over time, you get more and more of these RGCs that are being lost. The optic nerve progressively kind of deteriorates, and patients are losing portions of the visual field, like Dr. Wang was talking about, as this silent thief of sight.
And I know Dr. Wang mentioned that it is irreversible. What is maybe specific about retinal ganglion cells or other cells in the retina that make their damage essentially at this point irreversible? So if they're lost, they're lost. Because we know we have other cells in the body. You've got skin cells, you've got other cells in other organs that, if there's a little bit of a damage, they can create new cells. But this doesn't seem to be the case for these retinal ganglion cells.
Yes. So there is no natural way, really, for in humans, at least, to replace retinal ganglion cells. Retinal ganglion cells are neurons. They're called projection neurons, long distance projection neurons, that connect your eye with the brain. And really, for any neurons, for the most part, throughout your central nervous system, they don't really have the ability to be replaced. There's not a kind of a reserve of cells there. And because these neurons are also at this like terminally differentiated state, they're no longer capable of dividing on their own. So they're not able to kind of make more copies of their own. Our bodies don't really have a way to replace these when they are lost. Now, the good thing is that typically we do have kind of an excess of retinal ganglion cells. So it's not a matter of losing a small number of retinal ganglion cells is going to cause problems. All of us, as part of the aging process, will lose some retinal ganglion cells over time, and for many people, it'll never become problematic. But in glaucoma or other optic neuropathies, you're getting that loss beyond a certain threshold where you'll start having some of these visual field problems. And getting back to what Dr. Wang referred to as the silent thief of sight is because as you're losing these cells over time, over many years, this is happening silently. You don't know, you don't notice any differences in your visual perception. This is not something that's associated with any kind of pain or anything. So you lose a number. What distinguishes glaucoma or other optic neuropathies from just normal age is that the speed of that is kind of advanced. So you're losing really an abundance of these retinal ganglion cells.
Okay, thank you. And so currently, if you lose the cells, irreversible, but I know you're using a type of cell called a stem cell or stem cell models to both study the optic nerve and glaucoma, but also to maybe in the future try to replace some of these cells. I was wondering if you could just talk a little bit about the models that you're using and what they're letting you sort of understand or test that maybe we couldn't have done before we had these types of cells and cell models.
Sure. Yeah, I think there's a lot of exciting work going on for the use of stem cells relevant for glaucoma, including in my lab and, of course, a number of other prominent labs around the world. And it really falls into a few main categories. The big grand goal would be when a patient with glaucoma has lost so many retinal ganglion cells that it leads to loss of vision, and there's just not enough there to fix to restore that vision. The ultimate goal is going to be in trying to replace those cells. So you could think of using stem cells to then, in the lab, generate new retinal ganglion cells, kind of as like spare parts, and then replacing those cells in a disease state like that, like glaucoma. That brings a number of challenges. Um, there's a lot of different steps that are involved there. You're going to have to be generating the cells and then get them to be transplanted, get them to survive, get them to integrate in the retina, get them to make these really long distance projections to target with your brain, make proper connections. So that's not an easy task. So there's a lot of really great work going on in that space. But you can imagine this is not just like a one thing needs to be met. There's a lot of really big, formidable obstacles in the way of that. So this is not around the corner, right? Don't want to give false hope. It's exciting, and I think it's very promising, but it's going to take a lot of work. So where the other side of things in the research community tends to fall with the use of stem cells is to use these cells as a platform in the lab to better understand what goes wrong in the cells in a disease like glaucoma. So when we use human stem cell models, we can create retinal ganglion cells in the dish from these stem cells. And this gives us now a system where we can kind of observe disease mechanisms in these living human retinal ganglion cells. And I think that's kind of a key because there's a lot of great work that's being done with your traditional laboratory animal models like lab mice and so forth. And we've learned a lot from that. But at the end of the day, fundamentally, rodents are not humans or humans are not rodents, and there are fundamental differences there. And this is one of the reasons why it's thought that so many new kind of drug discoveries that seem really promising end up failing in clinical trials because we're not bridging that gap particularly well. So what we think is that the use of human stem cell models like this will allow us to generate the retinal ganglion cells and then try to better understand what's going wrong. When you have a better understanding of what's going wrong, you can then be more targeted in your strategies to try to fix that. So using these stem cells, we can kind of study what some of those early cellular changes are before the cells even die in the first place, before we need to replace them. If we can figure out what's going wrong early during that silent period, the silent thief of sight, we can then have much better chances of identifying neuroprotective kind of strategies to keep the retinal ganglion cells we have in the first place, try to keep them happy and healthy as long as possible.
I think that's a really important sort of distinction. The idea of using these cells as tools to better understand the disease is like one very, very important area of research. And then the second area of research is actually using the cells to potentially replace cells if we haven't developed treatments. But I guess the ultimate goal would be to always either prevent it or prevent vision loss happening in the first place before we actually even need to replace those cells. So thank you for going through all those. Dr. Wang, I'm going to jump back to you about, I know both of you have been talking a little bit about that lowering eye pressure is important if you've got glaucoma for many people, but there's also other potential factors at play. So first of all, can I ask you to maybe just describe briefly about why, for many people, it's really important to reduce pressure to protect the optic nerve? So why are people taking drops or doing other things to reduce the pressure? But for some people, it doesn't work. So if you could talk a little bit about that patient population as well.
Of course, and I'm very happy that you asked this important question. First of all, as a glaucoma specialist, as I tell all of my patients with glaucoma, regardless of their subtype of glaucoma, I think just now I saw somebody asking a question on normal tension glaucoma or otherwise low tension glaucoma. The thing is, all of our proven therapy, whether it's eye drops, oral medication, laser treatment, or surgery, they all have one common goal: is really to bring down the pressure. So I tell my patient this is very important and first and foremost goal to achieve. And we have very good data to support that, even in patients, for instance, having normal tension glaucoma, significant eye pressure reduction have shown protective effect against glaucoma progression. And there are also clinical studies that have shown that just by lowering the pressure alone, do have neuroprotective and neuroenhancement impact. This being said, you're absolutely right, Larissa, is that in every glaucoma specialist practice, we all have a minority of patients in whom, despite a very low pressure, sometimes even in the single digit, and despite that excellent pressure control, continue to show visual field progression. And that exposes really the unmet need for us to search for other kind of treatment, not just focusing on the pressure lowering route. This being said, I'm repeating myself, it's still very important to have your eye pressure under control before we start considering other aspects.
So for most patients, the pressure lowering is still the main way of...
For all of the patients.
For all patients. Okay, so that's good to know. So
Yeah.
You should be definitely going for your regular appointments, continuing to take your drops,
definitely.
Checking your eye pressure for everyone.
Correct. Yes.
Okay. That is our big PSA of the day, is making sure you're going for regular appointments if you're at risk of glaucoma, or especially if you already have been diagnosed with glaucoma.
Totally.
Yeah. Dr. Meyer, I just want to talk a little bit more about the idea of what sort of, to you, regeneration means in the terms of this field. So looking, in 5 years, 10 years, what do you think it realistically means about where the field could be in terms of restoring vision with optic nerve damage?
Sure. Well, so when we talk about regeneration in the context of glaucoma, I can kind of break it down to a couple different ways. One is when the axons of the retinal ganglion cells we have in our eyes are degenerating. One is we want to try to regenerate them. We want to get them to stop pulling back. We want to induce them to start growing back towards their targets in the brain. And so there's a lot of exciting research in that area where we are trying to slow that progression or reverse that pulling back of the axons and their connections and get them to reconnect. The other side of things could be when there is significant visual field loss already that is typically going to be associated with a pretty significant amount of retinal ganglion cells that have already been lost. So in that context, regeneration can also be expanded a little bit to the idea of trying to replace the cells that have been lost. So that would require trying to put new cells in place of the retinal ganglion cells that have been lost in our eyes. And then in that context, then trying to get them to grow axons towards the brain. Um, Either of those scenarios, the goal is to really try to get greater growth of those axons to the targets in the brain. Um, and that's not an easy task. Remember, these are long distance projections. So they're going to have to grow through the optic nerve, which sometimes could be over like several centimeters in length. So when you're talking about individual cells that are microscopic, they in proportion, several centimeters for a cell is a huge distance. So this is a formidable task. If they are able to reach their targets, then part of that regeneration is also making sure they can make those functional connections. So not that they're just not there, shaking hands with their neighbors, but actually functionally communicating with their neighbors that they're supposed to in the brain. Um, so I think the concept of regeneration is going to tie in all of these components.
And where would you say the field is right now with a few of those steps, both in terms of if the cells are there, making the axons grow a bit longer, or actually putting back new cells into, I mean, we're definitely not at human clinical trials, but like, are we at mouse models? Like where is sort of the field, or what are the big questions the field is currently really addressing?
Mhm. From a research perspective, I think that there's really been a lot of exciting developments over the past several years, so it is very promising. I think that, and Dr. Wang can certainly chime in here with her more medical training. I'm from the more research perspective, so I don't want to give anything that's interpreted as medical advice, but I think practically speaking, it just makes sense that the best thing would be to try to catch and get a disease diagnosis early while you still have some retinal ganglion cells there, because you're starting with a foundation to build off of. The cells are there, hopefully the axons are at least partially grown, and you're shrinking down the distance where you need that regeneration. Um, and I think that is still formidable, but it gives us more to work with. And there's some really exciting research that involves things like looking at what's called neuroprotective compounds, things that will induce better survival and overall health that might then be associated with further growth. There are strategies looking at gene therapy to try to express certain kinds of genes in the cells that are associated with longer axonal growth. There's work using stimulation by electrical fields to try to use electrical fields to then further stimulate axonal growth. And all of these, I think, are really important areas to research. Once you get to that stage when you have substantial loss of the retinal ganglion cells, this is a bigger task, but I would say really just over the past 5 years, there's been a lot of great advances made in your common animal models, lab models like mice, and also once it starts getting to larger preclinical models, because the advancements have been made in the rodent models to look at replacement of retinal ganglion cells. So I think the field has gotten to be, made some really important advances in getting the cells when you're trying to replace them to differentiate the retinal ganglion cells from stem cells. We can then transplant them, and then they do integrate reasonably well in the retina. They'll extend some axons where the deficiency still occurs, and where we really need to put a lot of the effort moving forward is getting that growth through the optic nerve, or that long distance growth. But compared to where we were just 5 or so years ago, it's leaps and bounds better. So it is a really exciting time to be involved in this kind of research.
Has there been something in the field that has really like accelerated the research in this area? Is it like the focus on the area? Is it better models? What's sort of happening right now?
Um, I mean, there's always a lot of great research going on, so I feel like I will, inadvertently leave out some things. So I don't want to claim this is an exhaustive answer,
Mhm.
but in recognizing that I do work with stem cell models, I'm exposing a little bias mine. However, I do think that this has been an area that's really exploded lately. It was just within the past decade that people have started to even describe the ability to get retinal ganglion cells from stem cells. And in less than 10 years, now we're at the point where we have these as really strong foundational platforms to better understand the disease. And this is something that there are pharmaceutical companies using these stem cell derived retinal ganglion cells now derived from human patients as a platform for drug discovery. So I
Mhm.
think this is a very rapid turn of events to go from essentially nothing to now larger pharma companies are using as a platform to screen for drug discovery. And I think we've made a really substantial progress in the replacement of these cells. So I think the use of human cellular models provides us with a really powerful tool that spans many, many disciplines. And I think this is going to have profound effects and consequences for glaucoma treatments, whether it's development of new pharmaceuticals or other kind of treatment approaches, or for regenerative medicine.
Thank you. That's really exciting. Dr. Wang, I want to bring you in on the conversation because I know that you are part of your research is looking at what I would consider probably a neuroprotective, potentially restorative therapy. So I was wondering if you could talk a little bit about the clinical trial that you have been involved in studying insulin eye drops as a potential treatment for glaucoma.
Yes, of course. So first and foremost, I think it's important to point out that it's a exciting challenge that we actually have so many mechanisms, so many different strategies, as many of which are very brilliantly explained by Dr. Meyer. Um, but all of them actually represent potential targets for our scientists, clinicians to find potential solutions to. So insulin is one of those one of those quests. um I think for most people, insulin is more known as a peripheral hormone that's important in regulating our blood sugar level. So it's actually a treatment that's for diabetic patients. However, it's also a hormone that can very easily diffuse into the brain, into neurological tissues, and actually our optic nerve is an extension of our brain. And with all the research that's being done, we know that it plays a crucial role in maintaining the health of neurological tissues. And obviously, the idea of using insulin as a potential glaucoma treatment did not came out of the blue. We have earlier on observational and epidemiological studies that do suggest that diabetes, so people with insulin resistance, is an independent risk factor for open-angle glaucoma. But what really confirmed its role is really through some spectacular work from my former research fellowship mentor and now collaborator, Dr. Adriana Di Polo and her team, is that they've shown in experimental, so animal models of optic nerve injury, whether it's by cutting the optic nerve, so more like a traumatic model, or through a glaucoma model where the eye pressure is raised significantly, and to show that the retinal ganglion cell has undergone atrophy. So they have shrunken and even decreased in their numbers. The application of insulin was able to rescue many of those cells and even succeeded in reestablishing that anatomical structure, so that growing back part of their, I guess, their network. So this really lays the foundation of what's currently going on as translational study, and so far we've had very reassuring safety data coming out from phase 1 clinical trial. But and as Dr. Mayer very correctly pointed out, rodent eyes, mice eyes, are not exactly the same as human eyes. So we still very much need to demonstrate, and hopefully that insulin is as effective in reestablishing our vision functions as it was able to do in rodent eyes.
Thank you. I always sort of love hearing when there's a treatment that is being proven to be used and potentially effective for one disease being sort of used for another one. But are there any challenges just from a practical point of view in trying to do clinical trials, which I know can be really expensive for a treatment, which I'm assuming is largely off patent? And so there isn't necessarily a huge money making potential out of insulin eye drops, or correct me if I'm wrong, maybe there's a huge money making potential.
Totally. I think it touched upon many different logistic obstacles that we face. First of all, I think from a regulatory point of view, given that this is a off-label use. So when we say off-label is that when we use the medication not for the approved indication, here insulin versus diabetes. So whenever we're in that situation or with the off-label route of delivery, and in our trial we use it in the form of eye drops instead of through injection, as it usually is the way for diabetes treatment. So our regulatory bodies here in Canada is Health Canada, it will be FDA in the US, really set stringent standards to ensure patient safety, which I think it's paramount. But obviously, in order to get the approval, or at least their non-objection to us carrying out the process, it adds different, many different steps of control, so that by the time we're able to recruit patients, we know that we've supplied sufficient or reasonable amount of evidence to them to say that, hey, we have all the safety check in place for our patients. And obviously, given that it's a molecule that's already very universally available, I think it generates less interest in terms of the big pharma, because simply the market of diabetes treatment completely outweighs the interest of glaucoma treatment, or specifically neurodegenerative glaucoma treatment. So those are the things that we face, and this is why it's so important to have support, from research funding from Fighting Blindness Canada, for which we're very grateful for.
Yeah, I'm running out of time, and I know we want to get to audience questions. So just last, in sort of 30 seconds, first to Dr. Meyer, then to Dr. Wang. What are you sort of most excited about, like thinking either back through your career and where we are now, or looking forward in this field? Dr. Meyer.
Yeah. I'm excited about a lot of things. I think there's a lot of really exciting approaches that are really going to be very informative and instructive for us to develop better treatments. I do think that the use of stem cell-derived retinal ganglion cells is continuing to be transformative and will continue to be transformative, both from their ability to serve as a platform for drug discovery and ensuring safety and toxicity efficacy in a human cellular platform, but also for regenerative medicine when we try to replace these retinal ganglion cells.
Thank you. And Dr. Wang.
I'm just super thrilled at the potential that one day, as a glaucoma specialist in my clinic, receiving a patient who's losing vision, that I no longer give the speech of saying that unfortunately we can keep what you still have, but I cannot bring back what's lost. And I'm really hopeful that in the near future we would at least have different options to help us to regain some of that vision. So yeah, to be followed. And obviously I'm super excited also at the stem cell work, that's the very important work that Dr. Meyer is working on, and I think it definitely provides important platforms for clinicians and visual scientists.
Okay, well, thank you both for such a great wide-ranging discussion. I think it's super encouraging to hear progress, not only sort of thinking about new therapeutic approaches, but I really appreciate, Dr. Meyer, you talking about the impact that the models is having on helping develop our understanding of disease mechanism, which of course leads to new therapies as well. So I'm going to now step off camera, and I'm going to hand things back to Morgan, who is going to guide our audience Q&A. So thank you both.
Marissa?
Yeah, Dr. Moniz.
Okay, great. So let's get into questions. I see that we have a lot of questions in the chat and in the Q&A. So let's start with a more of a research question, asking, to what degree does research into spinal cord issues and blindness or glaucoma overlap? I'll maybe throw that to Dr. Meyer.
Yeah, I think that's a really interesting question. I think there's more overlap than people often think. You think the eyes at the right front of your face, spinal cord, and your back, it seems like they're pretty distant. Um, and there are important differences there. We can't say it's exactly the same. However, your retina, your optic nerve, and your spinal cord are all part of your central nervous system. So they do share a number of things in common as well. And I think that there are a lot of biological pathways that we can get a better understanding and inspiration from looking at one versus the other. So there are certain things we've focused a lot talking today on the retinal ganglion cells, which are the nerve cells that will connect your eye and your brain. And fundamentally, when those are damaged and lost, that's what causes the vision loss in glaucoma. But they are also very heavily influenced by a number of supporting cells around them, broadly called glial cells. So glial cells should keep the retinal ganglion cells kind of happy and healthy. But if there's something wrong with the glial cells, then the retinal ganglion cells lose their support, and really it's a compounding effect. And this is something that's not just seen in glaucoma. This is seen in other neurodegenerative diseases. So spinal cord diseases, so like ALS or spinal cord injury, absolutely, or even other diseases in the brain, Alzheimer's and Parkinson's will have some component there. So I think there are important lessons we can learn both from a research perspective by looking at research into other diseases, but potentially also for treatment strategies. I should also point out that while we focus a lot on the elevated pressure in the eye associated with glaucoma, there are genetic determinants associated with glaucoma that may even be found in the absence of this elevated pressure. And some of these genetic variants are very, very similar. Certain genes have different variants, but the same gene. Sometimes it causes glaucoma, sometimes it causes ALS. Why that is, we don't really have a great grasp of yet, but certainly it hints that there are important shared mechanisms there.
And that's, I guess, the scientific dilemma, right? The more we learn, the less we know, right? So there's still so many things that need to be figured out there around those connections. So we have a lot of questions I'm noticing about drops. So someone is asking if laser is recommended for glaucoma or eye drops for life is better. So maybe we'll start with that.
It's
Dr.
an excellent
Wang.
question. So I think previously, as I mentioned, all of those different modalities of treatment really aim to bring your pressure down. Whether one treatment is more appropriate for someone's eye, it depends on several factors. Glaucoma is just a big umbrella term. Clinically speaking, there's so many different categories of diagnoses. We can have we can have angle closure glaucoma, we can have open angle glaucoma. So, in terms of the feasibility of a laser treatment, here, once again, in glaucoma, we have access to different kinds of laser treatment. So, the neighbor who underwent a certain laser treatment may not be what you have in mind or what your doctor has proposed to you. So the feasibility of those lasers depends on the actual diagnosis of glaucoma. And then again, also whether, in terms of drops are excellent. All of those all of those products before their approval, they have to show to the regulatory bodies that they are actually effective in reducing pressure. So there's no doubt about the effectiveness. However, I often tell my patients, even the best drop in the world will not work if it sits on your desk and not getting put in the eye. So I think compliance is something that's very big, a big challenge for our glaucoma patients. So I don't have a very good question for a very good answer to your specific question. I think it's very important to look at this with your eye care provider, because it's not a cookie cutter approach. It's not one solution fits all. But keep in mind, they both aim to reduce the eye pressure.
Yeah, and I mean, even with drops, like there's another comment here from someone saying that they've used like 4 different drops over the course of their diagnosis, right? So I guess
Yeah.
it's all about what's working for you now and what if it stops working, trying something new, or if there's side effects, that there's different drops that can be tried. Someone had also asked a very similar question, but around
Yes.
drain or stents in the eye. Can you talk a little bit
Right.
about what that would be used for?
Yeah, of course. So, in contrary to like 20 years ago, today's glaucoma, especially in the surgical treatment sphere, it's it's a lot more exciting because suddenly we have many different devices. So I think, iStent, Hydrus, those to name a few, those are what we call angle-based procedures. So those are stents that we can easily incorporate while doing cataract surgery or standalone on their own. The goal here is really to optimize the natural functioning of a patient's natural drainage system. So we're not trying to reinvent the wheel. We're really just hoping to make a system that's maybe underperforming and to boost up their natural potential. As to why proceeding with that, it depends. For some people, it may be because we're already maximized on eye drops and we're still not happy with the pressure control. For other patients, is maybe they're having tremendous intolerance or allergy issues from their drops, and we're really in search of a drop-free option by offering either laser or by offering, these angle-based surgeries. And of course, for people with more advanced disease, we also have the more robust glaucoma surgeries that's available, trabeculectomies, the different newer implants, and also glaucoma drainage, this device, otherwise known as tubes.
Yeah, it's interesting too. There's a couple of questions. I think one came through email, and there was another one somewhere. I'm trying to find it. But if they have like other conditions that are preventing them from using certain drops, so there's like what's the word I'm looking for? Like they're not indicated for use when they're on other drugs. Yeah,
Contraindication.
contraindication. Thank you. That's the word.
Yeah.
When they're on other drugs. So would these types of procedures be something that they should investigate with their ophthalmologist, obviously?
Yeah, of course. So in my, for instance, whenever I receive a consult, a new patient in my office, there are a list of questions that I usually ask. So, like obviously, typically, if you have a known allergy to any of the components of the drops, that would be a clear contraindication. But things like, asthma, or congestive heart failure, things like that can also become a contraindication to certain types of drops. And lastly, sometimes certain of our drops can have local cosmetic changes in the sense that it can darken eye color. So for a small set of my patients, they would prefer to keep their original eye color, and in that case, we would oftentimes try to find other kind of solutions. Once again, that brings back to my initial point. I think it's very important that you discuss this with your eye care provider because once again, glaucoma care is not a cookie cutter approach, and the important thing is that you find what works best for you that suits your need while protecting the residual vision.
Thank you. I'm going to hop back to Dr. Meyer for a moment. So we have a bunch of questions, of course, about stem cell work. Every time we talk about stem cells, there's so many questions. So for example, I think there was someone here in the chat that was saying, and again, I think this is a good point that, I think there might be, like out there in the world, there might be some misconception that glaucoma is only for older adults. But this example in the chat is that this woman's son, who's very young, 6 years old, was born with infantile glaucoma and has lost vision loss, or has permanent vision loss. So the chances of him being able to get stem cell transplants to regenerate his optic nerve, and asking if there's further advancements in other countries such as Europe, or if everyone's sort of on the same sort of page that you've been talking about before.
In the context of stem cells, again, like Dr. Wang was saying, this is not cookie cutter, and I'll add on also, I'm not in position to offer any kind of medical advice, but I would say that it's important to consider what the underlying cause of the glaucoma is there. So without knowing that a little bit more, if you were to even try to replace the retinal ganglion cells that are degenerating, but you haven't really addressed the underlying problem, you're not fixing anything. Those same cells that you're trying to use to replace will likely suffer and be lost as well. So it really need to be known what the underlying cause is there. Um, there is a lot of important work being done in terms of clinical trials using stem cells for certain vision loss disorders, but that's more at this point. The advances there are more in other cell types of the retina, like the retinal pigment epithelium and photoreceptors to an extent. The retinal ganglion cells that would be more relevant for glaucoma are not as far along. They're not in clinical trials, or I'm not aware of going into clinical trials anytime too soon. I would argue probably because it is just a lot more complicated to make those long distance connections with the brain. We just have not gotten that progress experimentally yet to get to that point. So, I do want to be encouraging and say that I think that the potential may be there in the hopefully not too distant future. Um, but it doesn't really matter what country it is now. The technology isn't there right now, and it would also depend on what the underlying cause is. And I think that's an important consideration. I think that for in a case like that, I guess my recommendation would be not so much a stem cell approach, but what are some of the other things? So even something like the insulin eye drop. So it's that work that's been done there at University of Montreal has really been fascinating. It's exciting to have seen that go into clinical trials there. I think those kinds of neuroprotective and regenerative strategies are probably much more likely to pay dividends in the near future.
Yeah, closer to development for sure. And I wonder if we could talk, because I know we get a lot of inquiries in our health information line about stem cells and, advertisements from stem cell clinics that exist now and, inject it in your eye and it'll, make you see. Could we talk a little bit about sort of that stem cell tourism and why that's dangerous and sort of what to look out for?
Yeah, so I will start by saying that there is nothing that has been critically validated and clinically proven to be effective using stem cells right now for glaucoma. So of course we would all love that to happen. We would all love there to be a magic bullet. Stem cells are no more a magic bullet than anything else, and it is not there right now. So the fact that stem cell tourism is a thing, and we refer to it as tourism, is because you can't go down the block or across town or to the nearest city to get it. You typically have to be traveling somewhere else, is because it ends up not being regulated there. So, don't want to paint with a broad brush, I guess, and we'd talk specifics, but the fact that it's not regulated does leave the potential there for it to be a snake oil of sorts, where they're full of a lot of promises and has not gone through the proper avenues to be proven to work. So it is not covered usually by any kind of insurance. So it comes at a cost of many tens of thousands of dollars. And you might say, well, what's the harm? Even if it doesn't work, okay, I'm willing to spend that money. Because it's not regulated, it's not free of harm. There have been numerous instances in these kinds of things where harm has been done. When it's in the eye, it could lead then to blindness even further, more so than you would have ever had developed in glaucoma or in other parts of the body. It could lead to infections and sepsis if not done under sterile conditions. And there have been examples, maybe not for glaucoma, but for other types of stem cell transplants where it has led to death. These are not trivial things. So while we understand certainly the desire, you kind of feel like you have nowhere else to turn. You need to be very, very cautious and really speak with your own physicians and talk to them and be very cautious about the stem cell tourism.
Yeah, and what I tell people is like a red flag is if they're asking you to pay for it, it's not like a legitimate clinical trial, right? Like clinical trials aren't going to ask you to pay for it because
Yes.
they are experiments that kind people volunteer their eyes and again, not free of risk to do these research studies. So they're not going to ask you to pay for it. If someone's asking you to pay for it, that's a big red flag. Um, So I know we're running out of time, but I have one more question for each of you. So, Dr. Meyer, so what are some of the biggest, speaking on the safety, what are some of the biggest safety concerns that scientists think about when you're developing sort of regenerative therapies in the eye?
Um, I would probably say if we want to make sure that when you're putting some kind of, biological cellular product in as a therapeutic avenue, we want to be really, really sure that we know exactly how those cells are going to respond. Um, because if they respond differently, we also want to make sure that we have some way to fix that. So stem cells are cells that are able to proliferate. They're exciting because they can form a variety of different cell types. And we're excited about that because we can get the cell type that we want, such as retinal ganglion cells. But how do we make sure we're properly controlling that so that it doesn't become other types of cells in your eye, which will be characteristic of type of tumor called a teratoma that is really this uncontrolled growth of multiple cell types. And this would be really, really a terrible thing to happen, not just for the patient, but for the entire field if there was something like that happening, because it would set back the field for, probably at least a decade, I would say, before, we were able to get back to where we were to continue making progress. So I think everyone is very, very conscientious of the potential that we have there and the excitement that's there, but also being very cautious because we don't want there to be unintended consequences.
Absolutely. Thank you. And Dr. Wang, one final question for you. I noticed we have several questions here about glaucoma and AMD, or age-related macular degeneration. And I wondered if you could talk a little bit about how those two conditions might relate to one another.
I think, I would say the biggest thing, it's probably more by association in the sense that both conditions tend to increase in their risk as people age. But there's really no interference between the two conditions. And even from a genetic point of view, we're talking about different genes for in certain case of familial type of involvement. So I would say mainly it is a little to say that what is the association between cholesterol and high blood pressure. So it's I think it points more to sharing similar demographic um, features.
And someone was asking about, so for like wet AMD, people get injections in the eye, and just I guess is there any connection between the eye pressure and then making those
Oh,
injections?
I see, I see. Yeah, so there is it's even if you think about it, if we're putting an injection, even though a small volume inside an eye, that's going to increase the pressure. So it is a potential risk factor for additional mechanical stress that we already talked about. Usually they're short lasting. Uh, most of my retina colleagues, they do check their pressure, check their patient's pressure pre and post the injection. For patients who are more at risk, sometimes they can do additional manipulation to lower down the eye pressure. So indeed, that can be a risk factor for people undergoing regular intraocular injections.
Thank you so much. I really appreciate both of you answering all of those questions. It is always a
Thank you.
little rapid fire, so I appreciate that. And for everyone out there who's asked their questions, thank you so much. We've had way more questions than we're able to answer today, so I will say a couple of things. Several of the questions that I've seen coming in are very specific to people's personal situations. And as Dr. Wang said, like no one on here is your doctor, so we can't necessarily make any sort of personal recommendations. So you should definitely see your ophthalmologist and talk about these concerns with them. If you're unsure of what to ask or you're feeling, overwhelmed, confused, I do again recommend our health information line. We can help you come up with a list of questions to ask your doctor, can show you what sort of credible research studies are being done out there right now, and provide, information on clinical trials. So I think Shawnee just put in the chat the email and the phone number for that, and we'll also send that in a follow-up email. But I do encourage you to use that resource if we haven't been able to answer your questions here today. So thank you both very much, Dr. Meyer and Dr. Wang. It was great to see you both, and thanks for all of the wonderful information. So we're going to move to the next part of our session today. Now that we've heard about the clinical and research side of glaucoma, we're going to shift our conversation to lived experience. So if you are new to these sort of sessions that we're doing, we're going to move from webinar, which is this platform, over to our Community Connect sessions, if you'd like to come. And then you'll have the opportunity there to meet and engage with other people who are living with glaucoma, as well as sometimes we have family members or caregivers that are join us as well. We have two wonderful facilitators who are going to guide the conversations over there in Community Connect. So before we end the webinar, I'd like to invite my colleague Ushani to join me, and she is going to introduce them to us. So I'll ask Ushani and Albert and Lydia to put their cameras on, and I will leave you to it.
Thanks, Morgan. Today's Community Connect session will be facilitated by Albert Ruel and Lydia Imbayago. Albert is a community leader and nonprofit administrator based in Parksville, British Columbia, with extensive experience in accessibility technologies and advocacy for people with vision loss. He brings first-hand insight into living with vision loss and using assistive tools, and volunteers with the Parksville Community Center Society and the Canadian Council of the Blind to support inclusive outreach and peer connection. Lydia is a marketing and brand strategy executive whose career spans Unilever, Zimbabwe's telecommunications sector, and digital media innovations across South Africa. Having built her professional identity around vision, she brings a uniquely layered perspective to living with progressive vision loss. Now based in London, Ontario, she shares a thoughtful perspective on living with progressive vision loss, including its emotional impact, navigating a shifting professional identity, and the role of family and community in adapting. I'd like to invite each of you to briefly introduce yourself, who you are, and how glaucoma affects your day-to-day life. Albert, we'll start with you.
All right, thank you so much. Well, gosh, introduce myself. I've got nothing to do for about a half an hour. How much time have you got? No, I'm just kidding. So you know what? I started this journey way back. I'm a couple of weeks away from my 70th birthday, and my journey to vision loss started when I was about 23, with my left eye failing immediately when I was about 23 or 24. The right eye, we had a lot of laser surgery, a lot of laser work done to it to try and seal off the blood vessels before they hemorrhage. The early condition I dealt with was not actually glaucoma. It was called retinal vasculitis. And so they tried to save my right eye, and they did give me another 10 or so years of slowly diminishing, somewhat useful vision before total blindness hit, somewhere around 34, 35 years of age. And then, of course, the lights went out for me completely when I was about 42. And, I was just a forest industry worker here on the West Coast. And, of course, the forest industry didn't want a blind guy wandering around the plant. So I was offered an opportunity to stay safe and stay home. So I went back to school and retooled, and I, very nicely had another 30 years of productive work in the blindness not-for-profit sector, with CNIB, CCB, back with CNIB again, and some other not-for-profit organizations. So I've had a varied life in the workplace over the years. I retired in 2020 and have just been a volunteer since then. How does it affect my daily life? Of course, it changes just about everything. Um, but I still do, gardening and woodworking. I managed to cut the grass here in our little backyard. I I do just about anything I want to do. I just do everything differently. They won't let me drive a car, but I'm sure that those driverless cars are going to help eventually. But no, I use a quite a basket full of assistive technology. I use the help of sighted folks around me if I need visual assistance. I mooch rides and I use taxis. I get to where I want to go when I want to get there. It's just a different way every day. So I don't know if that's a good enough summary.
That's perfect, Albert. Thank you so much, and I look forward to hearing more about your experience with assistive technology and tools during our Community Connect session. Lydia, I'm going to hand it over to you to share a little bit about yourself as well.
Well, I think I'm a newbie in comparison to Albert. I became aware of my diagnosis when I moved to Canada. So around about 22, 21. And unfortunately, the first person to notice did not actually communicate the diagnosis to me. And when I was trying to get LASIK done, because I hated wearing glasses, and I was trying to go glassless. And it was at that stage that, the news was then broken to me. So I have 10% loss in one eye and 90% in the other. I really struggle on the one side, but I have tried to push on. So denial was my thing. I just thought, I can do stuff. I can be normal. But night driving became a problem, and I had lots of other the invisibles that interacted with my activities of daily living, especially working. And I could not get accommodations in the workplace because I look normal. I present as normal. So that lack of acceptance from maybe the outside, coupled with my own lack of acceptance as well, that has run a lot of interference. But I now accept that I have a disability. I have a lot of uncertainty around it, but platforms like this, I'm realizing there's a lot more people out there that are struggling with vision and vision loss, and trying to access supports. Sometimes it's easy, other times it's not, because no one really prepares for adults presenting sometimes. So things are available for younger people, not so much for older people. Driving, I'm right at the intersection where the Ministry of Transport kind of thinks I can manage. I also think I can manage because there are one-eyed people that I've researched that are able to drive, but I would like some vision coaching, but accessing those supports. It's things that I'm hopeful about. So it's a journey, and I'm just starting.